Hello, everyone, ladies and gentlemen. Welcome to this edition of the Cameroon Town Hall for Healthcare Professionals. This is a platform that brings together healthcare professionals from Cameroon origin that are spread across the globe. We meet every fortnight to discuss issues relating to healthcare that affects our people back home and to look at ways in which we can improve and contribute to the healthcare situation in Cameroon. We meet every fortnight, as I mentioned. Last week, we were here to discuss family planning in Cameroon, and we had an amazing speaker, Dr. Samuel Ojong, who thrilled us with the reality of the situation as far as family planning is concerned in Cameroon. Of course, today we are going to be meeting a very, very interesting speaker who is someone highly respected in the field of neurology. And today we shall be discussing a very important topic that at least concerns each and every one of us, as we must at least have one or two relatives or friends that have suffered from stroke in the past. But of course, before we dive into the main issue for today, let us take a round with the people who will co-moderating this session and just to get their voices and salutation. Hello, Brian. Good to see you today.
Yeah, thanks, Elvis. It's really good to be back. I know I've been away for a couple of weeks, so it's really good to see you. And really thrilled. I think this is a really very important topic for discussion today. I'm also very thrilled that we have an excellent speaker to talk about the subject. So it's really good to see you, Dr. Mona. It's good to see you too.
Yeah. Thank you so much, Brian. It's good to see you and good to see the smile. And our chair is here as well. I'm happy he is not working today, and you can see he's not in the working mode. Hi, Chair. Good to see you.
Thank you, Elvis, and thank you, Brian. It's always a pleasure having you guys. I don't know how you make it every week, but it's always really a pleasure having you guys. And I just want to thank everyone who is here with us and to let them know that this platform really belongs to them and to all healthcare workers and lovers of good healthcare systems and providing good healthcare to the world and to Africa and to Cameroon in particular. So thank you very much. And
thank you for the
special thanks to the presenter for accepting our invitation to be part of this platform.
Yeah, thank you so much, Chair, and thanks for your leadership and all the hard work you do backstage to keep us running. And Christelle, bonjour et bienvenue.
Bonjour Elvis, bonsoir à tout le monde et j'espère que vous me suivez.
Oui.
Oui, ok. Bonsoir à chacun, bonjour, bon après-midi en fonction de où vous nous joignez et c'est un honneur renouvelé de vous revoir encore à cette nouvelle édition. Merci infiniment.
Merci beaucoup, and it's always a pleasure to have you and to see your beautiful smile all the time. And thank you for all the hard work you do. As far as the Cameroon Town Hall is concerned, you're always present, and that really shows how much sacrifice and dedication you do. We expect we will not be having Alison today because of other competing priorities, as well as Therese, who is also very committed. Louisa, we might have Louisa come in and out in the course of the session for today. And as I mentioned, we are going to have a very, very interesting guest today. It's rare to bring him here based on his very busy schedule and competing priorities, but just accepting to be here with us today is something we really hold dear at heart. And we really want to thank you, Dr. Ngarka, for accepting our invitation. He is a trusted authority when it comes to neurology in Cameroon, and we shall be listening to him. But before then, of course, let's get to our usual tradition of getting updates, but now not just COVID. Updates in COVID and monkeypox, and hand it over to our chair, Mona, for updates.
Okay, thank you, Elvis. So I'm going to share my screen. So I would start by just thanking Dr. Ngarka for accepting to be with us in the town hall, and he's been very, how do I say it? At least he took care of my mom after my mom had a stroke, and she's recovered a great deal. So I just want to thank him for that. Well, I would say that we are in a very difficult times in the world right now, where infectious disease is really driving a lot of decisions that we make. And we do know there are several centers of disease controls around the world trying to juggle around monkeypox, COVID, and also polio in the other hand, and there are other viruses like Marburg virus that are also circulating in different places in Africa. So that is why here I say it's really strategic for the world to start fighting infectious diseases and also dealing with chronic diseases. It becomes very difficult. And this is the first time in so many years that we have realized that life expectancy is actually dropping. In the past 3 years, because of the number of deaths that have occurred in Europe and in the US, life expectancy has actually dropped. This is in the US, and it's showing us that really we are not, there's no real improvement that has occurred over time. This has affected all races, and it's something we should take note of and try as much as possible to put in strategies to reduce mortality. Now you can see that the US is actually an outlier where other countries had been improving, but it has stayed stagnant and now it's decreasing. And the rest of the world too, every place where COVID was very rampant has seen a decrease in life expectancy. Now, talking about monkeypox is something that we really have to take into consideration in every system. Each and every one of us health workers need to know exactly what monkeypox is. I've been talking about this, but today I'm just going to give a summary. It's an autopox virus. For those who don't know the history, it was identified in the 1958, and this was identified in Belgium in the colonial, one of the colonial masters of the RDC Congo, and it was first identified in monkeys in Africa. So here we have two clades of monkeypox. There is a West African and the Central African clade, and the pandemic we're having right now, because it's spreading around the world, and just that the frequency of spread is actually decreasing, is coming mostly from the clade 2, which is the West African type. And you see here that the death rate is actually greater with those who get the Central African type compared to the West African type. Modes of transmission, I think all of you do know this. It can occur from animals to humans as primary transmission or secondary transmission from human to humans. And these are the various modes of transmission, which I'm not going to delay on. We do see that this is data as of today morning. Here you can see that the number of cases in the world is actually decreasing, which is a good thing. And that's why it's important to always declare an emergency early, especially so that other health systems can reinforce and learn to fight against a disease that could be of potential pandemic and also potential endemic in many areas in the world. Many countries have been involved. Many countries have had at least 1 or 2 cases. These are the different countries, with the United States having 21,000, almost 22,000 cases as of today. So here you can see in the different states in the US, California has overtaken New York City, where I reside. And you have Florida next, Texas. It just goes according to mostly the population density and the amount of gay population you do have, but the heterosexual population is going to be affected too, because there is cross-sexual activities occurring within these groups. And it's also becoming a sexually transmittable disease. So we do know that the classical monkeypox does has an incubation period from 5 to 13 days. And there are prodromic signs that could help you identify that you have this. And we do also have the classical rash, which I'm going to show you. Illness duration is usually 2 to 4 weeks. Here is a classical type. On my right, you do have lesions that were observed in endemic areas in Africa. On my left, you have lesions that were observed in 2003 when there was a monkeypox outbreak in the US. So these are the different skin rashes that you could see. For those who don't, you can get my slides after this, and if you want to use it for clinical reasons. So now we do have clinical disease in 2022. They are a bit different. We do have mostly localized rashes in the genital areas, perianal areas, everywhere where people do have sexual intercourse. You have proctitis, which is inflammation of the anal region. We do have oropharyngitis, those who do oral sex, and rarely do you have prodromic signs. So here you do have lesions that are found. So you need to really examine patients. You see some around the penis and also the vulva, the vagina area, and the perianal area. You also have lesions around the mouth, the throat, and this can also be stigmatizing. A lot of people will not come into the hospital. And here we do know that transmission is still direct contact, respiratory secretions, and people getting touching items and through placenta. So here are several things you can do once you observe a case. Most countries already have guidelines in place, and there is some antiviral treatments that are available. And vaccinia immune globulins are also available for patients for prevention. So the Janus vaccine is available and now can be given intradermally, and the dose have been reduced, and there are clinical trials going on in order to be able to vaccinate vulnerable populations as much as possible. Post-exposure prophylaxis, there are clinical trials actually going on to see if this works or not. It's controversial at the moment. And the treatments, we do have certain treatments, and the groups that need to be treated are those who are vulnerable, those who have HIV positive. A lot of those who have been infected have been also HIV positive patients. So we do have tecovirimat, which is one of the drugs that was given kind of an emergency use authorization, and we do have it available in most areas in the US, not available everywhere, also in Europe. So we need to be careful, and this actually reduces mortality. So there is IVIG, which can be used. There are other antivirals that I've listed here that are also available. Now going back over to COVID, we do know that right now the Omicron BA.5 is the most predominant variant circulating in the world. If you see here, I've canceled all the other Omicrons just because it's going. We're seeing that few variants have overtaken the BA.5 for the past months that we have been observing the pandemic. What is new is that we do have intranasal vaccines that have been approved in China and India. And the US has stayed back, but the technology actually developed in the US. So most universities and companies have actually moved to the third world to try to get this approval. So here is the world's first nasal COVID-19 vaccine approved in India based on Washington University technology. Here are several other clinical trials that are going on in the world for those who are interested. We also do have, for those who have been following this, we had the monovalent vaccines. Now we have bivalent vaccines, several types of bivalent vaccines with different strains. You have the mother strain or the original Wuhan strain combined with the BA.5 and BA.4, and that's what is going to be given soon to, I think in the next few days by September 30th, you're going to have this available. And there is data to support it. There are others who are asking questions, why do we have to combine the original strain to this? I think you don't want to forget about the origin of the vaccine, and that this virus is actually mutating and can mutate in any direction. So the original strain itself had been very, very protective over time. So here are the advantages and disadvantages for those who want to know why we are combining this. And actually it has proven that it's more neutralization against BA.5 while when we give this, and that's really one of the reasons that this is going to be approved. One of the disadvantages is that no clinical trial has been carried out in humans. We have used the same technology we do use for flu virus in order to approve the vaccine, which is doing research in animals and then getting it approved. So here you can see that once it's combined, we do have better protection, and that is why lower viral loads. And we think that this vaccine, just as per the CDC recently, that is going to be given once a year. So this is going to be like the flu vaccine in the US and in also other countries in Europe where we do have a flu once yearly. And the rate of protection is really very great. Now you can see that by vaccinating, we have actually reduced, this is WHO data, we've reduced mortality and prevented a huge number of people from dying, averted deaths. And now we do have approval for children, which can be a whole discussion. And so the rate of vaccination in the US for kids is really very low. That in Europe is pretty high. And we do have the issue of long COVID, which is still going on. There's a lot of research going on around long COVID. What is the pathophysiology? We do have tiny clots. We do have persistent viremia. We do have distortion of the immune system being postulated. Now, this technology of messenger RNA and also nanoparticles is being used to help us in other technologies. We are having several vaccines trials on the way, not only of SARS-CoV. You have influenza vaccines, Zika, HIV, we do have Ebola, we have rabies, we do have malaria. They're all using this technology in order to develop vaccines. So these are the different trials being run by Moderna, by Pfizer, by others, CureVac, and GlaxoSmithKline in different arenas. So here you can see that in order for us to really be able to, the viruses get stable and can actually be transmitted. So right now we are BA.5, which is a predominant type. Where next, when are we going to have a new variant? It's only time, because you do have reservoirs in animals. We do have co-infections that are occurring, lack of global commitment, lack of global collaboration, no use of masks during certain activities. Everyone has abandoned the mask, and I still think it's an important part of it. You should wear it in the right situation. And we're still doing sewage surveillance, especially now with sewage surveillance in New York City. We're getting to see that there is polio circulating, and New York City actually declared a state of emergency about that. Now, wearing masks, I think things have relaxed a bit, and they have relaxed so fast. So it's something we need to take care of. If you're about to travel and you think if the prevalence of COVID is increasing, please still do wear your mask, because it does work. Here we can see that COVID actually at a certain point became the second cause of death, especially in Europe and in the US. Here is just the prevalence of COVID-19 virus with the BA.5 strain, which is circulating around the world. We still do know that vaccination prevents death almost 14 times compared to those who are not vaccinated. This is the data showing that. Now, this is 1 month ago. You could see that the circulating strains was BA.5, BA.4, BA.2.121, and BA.2. But right now, you can see as of yesterday, this is the circulating strain in the US. This is you can see that most of it is BA.5, which is taking over. And since we had the Omicron, we have not had any other variant. So this really tells us exactly how stable the Omicron is and how it has actually displaced every other potential variant. So this just shows you the transmissibility, the immune escape of the different variants and the different subvariants. You can look at this later on. I'll share my slides with you guys. And here is just showing you data exactly how the Wuhan strain has evolved over time and why we do need the mother strain to be there, the original strain, and also get some Omicron in order for us to get vaccination. So this shows you exactly how Omicron has had several subvariants, but still the BA.5, which was identified in South Africa and other places, is still very stable. So here is just showing the antigenetic distance between these variants. This is for people like Brian who are doing the genomics of this. So if you're interested, you can look at this. You can actually see the difference between the different variants, and you can see where the differences are. Now, is COVID over? COVID is not yet over. We're trying to close the door, but we need to learn to deal with this. We're getting to the finish line, but we are not reaching there because the finish line is running away from us. We need a Swiss cheese model in order for us to fight all pandemics always. So we need to be able to put several things in place. It's not just about treatment. It's not just about prevention. It's more about education. There are vaccines available now in Africa. There is an issue of vaccination hesitancy. There is an issue of education, and you would get to see exactly how we are still not vaccinating a lot of people. At first, we said the vaccine was going to be issue of vaccine equity. Now we do have vaccines, but people don't want to take them. So we are at the end of roads for masks, but I don't think we should be. Now, this is the COVID, the number of new cases is actually reducing, but if someone had told me 3 years ago that we would have more than 600 million people would have had COVID, I would have refused. And we would have more than 6.5 million deaths from COVID, I would have refused, which is an underestimation. And we're still having almost 63,000 deaths occurring every day. And we have given this vaccine already to 12, we have given 12 billion doses already. So this is not an experimental vaccine. I just want to tell people that few vaccines have given 12 billion doses in the world. I think no vaccine has done that before. So you can see this is the number of cases. In Cameroon, there was actually an update. In the past 2 months, this is the first time I found an update. And I can confirm this because there have been new cases. I've heard about people who got COVID recently. And we've had an update for the past 2 weeks. We've had more than 2,000 new cases updated in the COVID strain. So those who are back home, you should be careful. United States, as always, is championing the number of cases. Here, this has led to really a good discovery where we can actually reduce the time to development of vaccines. And this is very important in the world going forward. More than 12.6 billion shots have been given. Cameroon is still lagging behind. We have just 7 doses per 100 people that have been given in Cameroon. This is so low, but the question is COVID a priority? Is COVID supposed to be a priority? This can be a whole big public health discussion. And low-income countries still lagging behind. They are getting the worst kind of vaccines, but right now with vaccine equity, we're getting the best, and we're still unable to vaccinate our people. So this is just talking about a dream vaccine. It's important to know that data has not changed. Vaccines do work, and they do prevent death. They may not prevent transmission as much as we want, but they do prevent people from dying. And these are the different journals that were published in New England Journal of Medicine. And this is just showing you exactly the death rate among those who are vaccinated, unvaccinated, and those who have had a booster. So it's important to see, I always put this is a timeline for the development. This actually is going to be put in history as one of the times when humans took a year in order to develop a vaccine that was efficacious in preventing death. Now, are we done with all the variants? We are not. So when are we going to have pi? It's just a question of time. The world is, I hope the world doesn't lock up itself the way it did with Omicron in South Africa. I hope Africa gets ready in order to get a good cold chain. And also the dream vaccine is going to be a vaccine which is pan variant, which doesn't depend on the variant. And several places are working on that, with Walter Reed leading this in Maryland in the military research area. So for treatment, not much has changed in treatment. This is a summary slide for those who are in the clinical setup, what to do, what patients need. For patients who have COVID, you do have interleukin-6 receptors, tocilizumab. You have RNA polymerase, which is remdesivir, monopiravir. You do have protease inhibitors, which is called Paxlovid. We do have monoclonal antibodies that also vary depending on the variant you have, and you have a JAK2 kinase inhibitor, which is baricitinib. This is the different indications that you have for them. In the outpatient, that's where most of them are indicated. In the inpatient, we have just about 4 drugs, dexamethasone being the primary, tocilizumab, baricitinib, and remdesivir. So with my slides, you can see exactly which areas and when they are indicated and the doses of what needs to be given. Those who are back home, if you're having a surge in cases, you can use the slides in order to help you. All the doses are there, and tocilizumab may not be available in most places in Africa, but baricitinib is. It's a drug that is used for rheumatoid arthritis, and it's available. So here, those who want to learn about the mechanism of action, we do have it. It's important just to state that there are certain things that do not work, and it's important for you to know the things. EverShield, for those who are here in the US, those who have cancer, if you have a family member with cancer and they have had a vaccine, but in order to prevent them from getting COVID, you can give them this every 6 months. These are long-acting monoclonal antibodies. So here is just summarizing things that did not work during the pandemic. And a reminder before I close that a Swiss cheese model is always the best model for public health. I also talk as a public health physician that it's important for us to collaborate, get everything in place. And I just want to thank Elvis and Brian and Christelle for coordinating this session, and also thank Dr. Ngarka for being with us here today. So thank you, and let's start the session. Thanks.
Thank you. Yeah, thank you very much, Dr. Mono, for this very interesting update. And I would like you to just stay on point for us to get a little interaction while our presenter gets ready. If you were to be the Minister of Public Health in Cameroon, and maybe I hear there is, we are waiting some government reshufflement, maybe you could be. Imagine that you are given $5 million and this is for you to still address the situation of COVID-19, because there are new cases as you presented as far as the situation back home is concerned. But you need to be able to tell us the area in which you would allocate at least 70% of this budget. Will you prioritize giving the jab into the people's hands, or maybe increasing testing and identifying new cases and maybe just making sure that they don't spread? Or will you spend more on public health communication to aim at behavioral change to make sure that maybe people get back to masks and other hygiene situation like hand washing that can lead to prevention? Out of these 3 measures, which one will you put 70% of your budget?
Well, I will not distribute it the way you want me to, but I'm going to put a lot of my budget.
That's a condition that 70% have to be on one of those 3.
Most of my budget is going to go in education, and I'm going to explain why. Just because there's a lot of vaccine hesitancy, you do need to break that barrier. Without that, without educating the people about vaccination, about even the existence of COVID, you'll not be able to do the other measures. So education is going to go first. I'm going to put 70% of that. Thank God that the vaccines, we are not buying them. They are free, they are available. So after educating the people with the budget the ministry has, then I'm going to go to my donors and get the vaccines that they already have. And I'm going to vaccinate everyone who is eligible for vaccination, because it does help. And I will tell you this, it does really help. And I have family members back home, others who, I don't have family members who died, but I have family members back home who really got sick. Before vaccine, some of them were young, but after getting the vaccine, some of them did get COVID, and none of them actually died. So it's important to educate the people about the importance, get a committee in place to study the local thinking processes and use locals in order to prevent vaccine hesitancy. I'm not an expert in vaccine hesitancy. I hope Alison was here with Professor Wisonge. That's something we really need, because denial is actually the first step in everything. HIV spread in Africa because of denial. There was so much denial in the initial spread of HIV. If you get to read the change occurred really when the world organized the second HIV International Conference, and people in Uganda marched with corpses for the world to see. There were corpses that were lined up throughout the city and lined up, and the world saw the first time how HIV is true. That the people really accepted that HIV is true. And it got pharmaceutical companies to stop all they allowed India to produce generic drugs. Nobody could stay without being effaced by what happened. The world saw corpses lined up in the streets. And they made all pharmaceutical companies to see that. So at times when it gets to that point, people themselves, if you really get to the point what we saw in New York City, you get people really stand up and really take things seriously. It's not only COVID, but there's so many diseases that are emerging, and a lot of them have been neglected in Africa, including monkeypox. I have mixed feelings about WHO declaring an emergency. It's mixed just because I don't know why they did it now, but it's a disease that has been there for years and nobody cared about it.
Thank you, Mono. Thank you. And your answer is very political also, but very scientific. And so thank you so much for attempting to answer such a very challenging question, especially in a country where we think we have already conquered COVID-19. So it's very difficult to think that there is a one-size-fits-all kind of decision that can solve the situation. Ladies and gentlemen, if you are just tuning in, this is the Cameroon Town Hall for Healthcare Professionals. This is a platform that brings together healthcare professionals from around the world who are all Cameroonians. We come here every fortnight and to discuss on issues that affect the health of our people back home and to see how we can contribute to improve on the situation. Today, we are going to be having a very interesting topic, which is stroke management. And we are looking at what the challenges and the opportunities in Cameroon. We brought for you one of the best. He's a trusted authority and a neurologist in Cameroon who can best tell us as far as issues on stroke management is concerned. I thought of making an introduction of him, but there is another person who knows it even better than I do, who is going to do the introduction of our guest, and that is Dr. Brian Tegomo, who is going to now take the opportunity to introduce to you our speaker for today. And thereafter, we are going to dive directly into the presentation. Please take note, the presentation is going to run, and at the end, we shall have a session where we shall interact with our presenter, ask questions, get answers, and then we close the session. So Brian, take it from me, please.
Yeah, thanks a lot, Elvis, and also thanks, Dr. Mono, for that really brilliant introduction. It was interesting to hear how you would allocate those $5 million if you were the Minister of Health, and I hope that's a discussion we'll take in the parking lot after this. Really have to delve into that, and I'm really truly and deeply honored to be asked to introduce Dr. Ngarka Leonard. I was telling Elvis earlier before the call that I didn't feel competent enough to introduce him because of who he is, not only as a professional, but many of the things that he does or has done outside of academia and his professional engagement. He has helped to build a lot of leaders, a lot of mentored thousands of people. And he's the co-founder and president of an organization called World Changers Association. And they've been doing a phenomenal work in Cameroon and grooming next generation leaders and and he's had such a tremendous impact in the lives of thousands and just lots of people. I'm so deeply honored, and not really saying this out of humility, that he's really that good, and I have so much respect for him. Dr. Leonard Ngarka is, as you know, he's a neurologist and he's a lecturer. He's a researcher. He's the consultant neurologist at the Hôpital Central in Yaoundé, and also a clinical neurophysiologist at the Central Hospital. He has spent a lot of time with stroke management and epilepsy and sleep disorders and all vascular diseases. He lectures at the Faculty of Medicine and Biomedical Sciences, and I see there are many Cameroonians on the call, Cameroon Medical Student Associations on the call, because he's really that good. People come to listen to him because he's very good in articulating, really explaining concepts in neuroscience and neurology and the nervous system. He's also one of the research associates for a foundation that's called the Brain Research Africa Initiative. I think that was set up by Professor Njamshi a few years ago, and they've really been broadening and improving and increasing knowledge about the nervous system and nervous system disorders, and have had so many philanthropic efforts across Cameroon. And so it's just amazing to think about all the different ways in which Dr. Ngarka has had such a tremendous impact across the continent. He got his MD from Cameroon, and he did his neurology training in Cameroon, did his fellowship in the University of Cape Town in South Africa, and in Turkey as well, where he's had some additional training in his field in neurophysiology and neuroscience. He is currently an RF African Research Excellence Fund Fellow, so he's also been very much involved in continuing to be involved in scholarly work. It's my true and really distinct honor to introduce and to welcome Dr. Ngarka to the town hall. Thank you, Dr. Ngarka, for accepting the invitation, and it's really an honor to have you, and I look forward to your communication today.
Thank you very much, Brian. I think after your presentation, I feel it's quite difficult to talk because when you were talking, I was wondering if you were talking about me or someone else. But nevertheless, thank you very much for this warm introduction and this warm welcome. I'm very pleased to be here this evening, and I want to say thank you to the brains behind the town hall and for all what this movement has been doing for the past 2 or 3 years since it started. I'm really pleased to be here. I'm honored to be here and to talk about this subject, which permit me share my screen. Okay. I hope I'm doing the right thing. Sorry. Sorry. Okay. I think I'm sharing the wrong thing.
Yeah, you are not sharing your slide, but we are seeing your sharing. So maybe you get your slide. We'll be able to see it.
Yes, I'm about sharing my slide. Sorry. Okay.
That's fine.
All right. I'm really grateful to Dr. Mona and to Elvis for all what they are doing through the town hall. Can you see my slide, my sharing now? I hope it's.
No, not yet.
Okay. Sorry. Okay. Yes, I think I'm sharing the right thing now.
Yes.
Yes.
Okay, that's fine. Thank you people very much for all what you are doing through the town hall and for the challenge given me this evening to share on a subject which is not very easy to approach stroke management in Cameroon, current state, successes, challenges, and opportunities. For our presentation this evening, our desire to bring out the situation of stroke in Africa and Cameroon, to list some successes which have been recorded so far, enumerate some challenges which have been encountered, propose some points which we can work on in order to reduce the burden of stroke in Cameroon. And there is something I've not put on my objectives, which I think we will need to attain, is also to learn from you, because I believe that the stroke burden is so huge that neurologists cannot all handle it alone. We need more brains like you to come in and chip in your own contribution so that together we can fight and destroy this big elephant which is ravaging our population. So to meet our objectives, we adopted the following outline, and we'll start with a review on stroke. What is stroke? Stroke is a brain condition which is defined as sudden onset neurological deficit. What is that deficit? It could be a weakness either on the face, on the arm, or speech. That's why it is represented by FAST. Most of these symptoms are of sudden onset. It means nothing precedes it. Somebody who is initially fine, and out of a sudden he has either a face, arm, or speech weakness, and that must be intervened on as soon as possible, because it is said in stroke management that time is brain. There are different types of stroke that exist. We have the ischemic and the hemorrhagic stroke. The ischemic stroke is the most common type of stroke, which represents about 2/3 of all the different types of stroke. And there are different subtypes of ischemic stroke. We have transient ischemic attacks, and the most common mechanism of ischemic stroke could either be thrombotic or atherosclerotic. This is because we have an obstruction of blood supply to one part of the brain. As a result, we'll have a malfunction. Another type of stroke which is common is the hemorrhagic stroke, which accounts for about 1/4 of all the strokes that exist. Usually we have a rupture of a blood vessel and blood spills into the brain. The most common etiologies could either be aneurysmal or hypertension. Stroke has many risk factors. We have both modifiable and non-modifiable risk factors. The modifiable risk factors are those which we can do something about, and the most common ones are hypertension and diabetes, smoking and alcohol, sedentary lifestyle, and obesity are other modifiable risk factors. Non-modifiable risk factors which exist are age, and gender. I think we'll talk a little bit about the global burden of stroke, the epidemiology of stroke worldwide. I would say stroke is the second leading cause of mortality worldwide, and the third leading cause of disability adjusted life years lost in the world. In fact, I can summarize stroke with the figures 1, 2, 3. 1 says stroke is the first cause of preventable dementia. 2 is the second cause of mortality and is the third leading cause of disability adjusted life years. Worldwide, the burden or the cost of stroke management worldwide stands at 0.6% of global GDP. And between 1990 and 2009, over a period of 2 decades, we've had a substantial increase in stroke burden and prevalence and incidence worldwide. Looking at this diagram, this map, which shows the distribution of the incidence of stroke worldwide, we see that high-income countries have the lowest stroke incidences in the world, like we can see in America and Canada, who are all in blue. And low and middle-income countries have different shades of red, from the very dark red to bright red and to amber colors. And we can see here Cameroon with amber colored. With prevalences, we'll see here those in blue, the high-income countries have a prevalence of about 64 per 100,000 population, and those with very high prevalences, more than 218 new cases every year in 100,000 people. We can see that in Africa or low and middle income countries, the prevalences or the incidence, is very high. And knowing full well the problems which we have with reporting cases in sub-Saharan Africa, even this high incidence is even an underreported. It's underreported. It means that if we're to take all the data available, all the data which is, if we're to take real-time data on stroke, it's going to be higher than that. So most of the African countries will not only be in the amber or the bright red zones, they could even move to the dark red zones, meaning that the incidence of stroke in Africa is even far higher than we even imagine. And Africa, like we all know and have said earlier, finds itself in the band of low and middle income countries. Africa has a dual burden, the burden of non-communicable disease and the burden of infections, and this compounds to make a bad condition worse. Stroke alone accounts for the greatest population of non-communicable disease. And the global burden of stroke mortality in the world, 86% of this is found in low and middle income countries, with about half of these found in Africa. The risk factors for stroke in Africa are the same like we'll find in other parts of the world. We have hypertension, dyslipidemia, central obesity, psychosocial problems, problems with diet, and so on. And we have this study which was carried in America, which tried to study the prevalences of these vascular risk factors amongst different immigrant populations. We have indigenous Africans, African Americans, and Americans of European descent. And you will notice from here that most of these risk factors were significantly higher in indigenous Africans compared to African Americans and Americans of European descent, suggesting that there is possibly something amongst Africans which predisposes them to having most of these risk factors. And that's why further studies show that there are even some genes, like we have interleukin-6, ApoE, and CDKN2A and 2B, are some of the genes which have been discovered, which expose Africans to an increased likelihood of developing some of these vascular risk factors. And now, looking at the complications of stroke, I extracted a few. We see that after having a stroke, it's not just a no event. There are complications to that, and the complications are variable. Today, are varying. Sorry. Today we are celebrating a World Day to fight against suicide. Stroke alone is responsible for high rates of depression. It is shown that the prevalence of depression amongst victims of stroke ranges between 16 and 18%. So fighting stroke is one way trying to combat what we are celebrating, or we are trying to fight on September 10th, which is combating suicide, because high rates of depression in patients who've had a stroke increases suicidal thoughts and depression. Equally, we have other complications, which are cognitive impairment. We have pain, sexual dysfunction, which was present in more than 80% of patients with stroke, anxiety, fatigue, aphasia, bacteria, aspiration, pneumonia, and delirium. Just to say that these are some of the complications which we'll find in patients with stroke. And now, looking at stroke in Africa, what are some of the things that explain generally this high prevalence or this high incidence we'll have in our population? We have a population level risk factors, and we have genetic factors, and the underlying mechanism could either be epigenetic changes or fetal reprogramming. We have problems due to migration. We have more people move from rural areas to urban areas. We have increasing wealth, obesity, low intake of green vegetables, lack of physical activity. We can remember several years ago, most of our parents used to move a lot. They would trek from their homes to the farm. But now, with many people moving from the rural areas to urban areas, most of them get involved in activities that leave them to spend most of the time either on chairs in their offices and less time for sporting activities. We have air pollution, smoking, and increased HIV survivorship and treatment have also contributed in increasing the population risk in our communities. Also, we have our population is growing older. The African population is growing older than they were several years ago. And he who says aging of the population talks about neuroinflammatory mechanism, immunosenescence, atherosclerosis, microinflux and bleed, and other white matter changes which are equally risk factors of stroke. And after having spoken about the world, Africa, let's move a little bit into Cameroon. Cameroon is not left out. We see that the incidence in the number of deaths in Cameroon stand at about 11,000 per 100,000 the population, with about 6.5% of total deaths due to stroke. That means the death from stroke in our hospitals is really high. So it's important that something is done about it. All right. Beyond just the death, not everybody is going to die of stroke, but there's equally an economic part of it. The cost of managing stroke is very high. We have this study which was carried out in the Douala General Hospital, where some patients were followed up over a period of about 9 months. And we see that the average cost of stroke management over a period of 9 months stood at more than 800,000 francs CFA. And that means that about 90,000 francs a month. So you can imagine that stroke, whose management is not just for 9 months, is for a lifetime. So somebody has to spend about 90,000 more francs apart from his bills, just on prevention, secondary prevention. And this is in a population where the SMIT is less than 35,000. So imagine that a typical Cameroonian has stroke. The cost of managing of secondary prevention of stroke is even higher than any amount of his salary, which he is going to earn for over a year. This raises a serious problem. And from these studies which were carried out, we see something about the epidemiology of stroke. We see that it's most common in Cameroon between the ages of 55 and 64. And the younger population, they are not spared. We see that even young people as well have stroke. We can see people between the age of 25 and 34, they equally have strokes. I remember a few years ago, I think not even a few years, that's exactly last year, on a weekend where one of our colleagues, a medical person, they called me. I think he's 28 years old. He said he was feeling dizzy. And I asked him to come to the hospital. After we examined him, I thought this guy had signs of stroke. And we did imaging. This guy had a brainstem infarct at 28 years. And anytime we go to our wards, we will always find stroke patients between the age of 30 and 40. That is to say that stroke is not a disease of the old as we used to think. It is affecting more and more even the younger population or the younger age groups. So it's important that the old and the young as well, they're educated on stroke so that we can join our hands together to combat and to fight this. We see, okay, the risk factors in Cameroon remain the same, like we know in other African countries, like we mentioned earlier. And why is the burden of stroke really high in Cameroon? Why is this burden high in Cameroon and in Africa? The main reasons are due to lifestyle changes. We have health and demographic transition. We have health, lifestyle habits, sedentary lifestyles, rise in obesity, rise in hypertension. Several years ago, you grew up, there were some things which we couldn't have because of means, but now that you have money, it's possible that you afford such. And so we go ahead to consume them in very high quantities, not knowing that these things which we are eating have an impact on our health. I mean, for someone who grew up in Bamenda several years ago, we were told that a child is not supposed to eat eggs. Because if you eat so many, you are going to become a thief. You are going to steal tomorrow. So your eggs, the number of eggs you ate a day or a week were reduced to 1 or 1 in 2 weeks. But now that you've had a job and you earn some money, you say, no, let me eat what I couldn't have when I was younger. And so you can eat the eggs every day with the Irish potato, which you didn't have the privilege of eating when you were younger. Not knowing that the more you are consuming such, those are the risk factors that you are compounding by doing that. And so we won't be surprised that we have this non-communicable disease at an early age. Just to say that most of the causes of stroke in our population, they are preventable. Even amongst the young, stroke risk factors are similar to those we have in the older population. We used to think that in the young, they were mostly genetic, but these vascular risk factors are common amongst the young. But now let's talk a little bit about stroke management in Cameroon. Normally, there is an algorithm by World Stroke Organization about stroke management. We have 3 levels of stroke management. We have pre-hospital care, we have hospital care, and post-hospital care. And the ultimate goal with all of this is that for someone who's had a stroke, he needs to be received in the hospital within 1 hour. And all imaging and everything needs to be done such that this patient, if eligible for thrombolysis, that should be done within 4 hours, 30 minutes from the onset of symptoms. So the objective is someone who has a stroke, that nobody has a stroke, but if somebody has a stroke, between the time when he had either facial weakness, arm weakness, or speech problem, and the time where an intervention is done, either by thrombectomy or thrombolysis, it must not exceed 4 hours, 30 minutes. That's what is called the door to needle time. And for pre-hospital care, what are the different components of pre-hospital care? This involves sensitizing the population about the risk factors of stroke, preparing even transport networks, making transportation easy for someone who's had a stroke to easily be carried from home to the hospital. If somebody has weakness, either a deficit, make available maybe a toll-free line where he can easily call the medical team and have treatment as soon as possible. As concerns stroke care, this talks about creation of stroke units and health and specialized personnel to manage people who've had a stroke. And for post-hospital care, that's rehabilitation. So between the pre-hospital care and hospital care, we have an objective of not exceeding 4.5 hours or 4 hours, 30 minutes after the onset of symptoms. But we have a serious challenge realizing all of this in Cameroon. And what are the challenges which we face? The first, concerning the pre-hospital care, is the low socioeconomic status of the people. People are not able to afford for care. People have inadequate knowledge about stroke. They have poor health-seeking behavior. When somebody has a weakness, the first thing he does maybe is to go to a traditional doctor somewhere and spends a lot of time there before ever coming to the hospital. All of these impedes stroke management in our setting. Also, because of poverty, that could be the main reason why they may not rush to the hospital. For those who even succeed to call the hospital to come early, to transport them from their homes to the hospital is a serious challenge because of traffic. And also because of poor education of the population. Imagine on the streets of Yaoundé, you will find a taxi driver fighting and insisting not to give way to an ambulance. I don't know where that happens. Normally an ambulance has priority, but you will, on our streets, an ambulance will not be given a priority by a taxi driver because he's in a haste to carry a passenger or to get his 200 francs from a client who is just a few meters away from him. And all of this come to impede real stroke, pre-hospital stroke management, because if somebody informs maybe the healthcare team on time, an ambulance came to pick him up, the time which he is going to spend either due to traffic or because of poor education of the people, maybe the gate man who refuses to open the gate and start fighting with the ambulance or the taxi that transports the patient. All of that leads to a delay in pre-hospital management of stroke. We have long consultation delays, inadequate prevention strategies, little or no healthcare policies on stroke, and like I said earlier, great difficulties with transportation. As for hospital management, it's true that we have many services that have been created now for stroke management, but they are not sufficient. So far in Cameroon, we have just about 2 neurology services, and neurologists are not found in all the regions of Cameroon. We have them just in about 5 regions of Cameroon. We have Yaoundé, Douala, Boya, Boya, Bafoussam, and and which I think just about 5 regions. So we see that we have a great part of Cameroon which are not covered by a neurologist. Also, we have technical difficulties. We have low rates of thrombolysis, and even if thrombolysis were to be done, the cost is not affordable to a common Cameroonian. The cost of getting the drug and getting that whole thing done is about 1.8 million. Which Cameroonian has that amount of money readily available so that when he reaches the hospital, he can disburse? And even and given that that money has to be paid because there's a problem of the healthcare system, people have to pay from their pockets. Imagine that you have stroke in the night and you are transported to the hospital that night. Will you have this amount of money available for you to pay at that time to get yourself thrombolized? Those are all the difficulties which we have for stroke management within the hospital milieu. And what about post-stroke care? We have a problem of a follow-up. We have problems of insufficient specialized centers and professionals to take care of these people. In the whole of Yaoundé, we have just 2 speech therapists. Imagine the number of patients we have with aphasia. And usually just to get an appointment to see a speech therapist is very, very challenging for most of these patients. And as a result, they end up abandoning. We have long consultation queues. People need to wait for, say, sometimes 2 or 3 months to see the specialist because they are few. All of these are some of the challenges which we have in post-stroke care in our population. But there are some things which have been done which are interesting. Over the past few months, the Minister of Public Health, the government of Cameroon, has constructed and inaugurated new hospitals in different regions. We call them the regional hospitals, the reference hospitals in different regions. Like we have one already inaugurated in the West region, Garoua, and the South region. And these hospitals are well equipped. At least some of them have up-to-date equipment to improve stroke care. And this is something which we have. Like we see this, most of them do have imaging machines available, meaning that more and more there is an increased ease to do imaging in most of our clients back home. We have more centers which have imaging and the different types of imaging, the MRIs, or all the different modalities of imaging which are needed in stroke management. Most of them are available back home. Also, in hospital management, we have more and more specialists in that domain. For those who need surgery, we have more specialists who can do that. We have our elder brother here, Esene, who is very passionate about vascular neurology. We have Professor Genche in the General Hospital who has equipped his center and can operate aneurysms. And we have more and more experts in the domain. We have more neurologists, we have more internists, we have more nurses, we have more physiotherapy training schools, and even more physiotherapists. All of these say that there is a lot has been done and a lot is ongoing in Cameroon. And this thrombolysis, which used to appear impossible in a milieu, we have this article which we just published about less than a week ago, which is the first recorded case or published case of thrombolysis in Cameroon. We can see it was published just 3 years ago and 3 days ago, yes, about 4 days ago. And we have 4 other cases which are on the line to be published, just to say that it is possible to offer some of these to Cameroonians. But now, are we going to focus on clinical practice, on clinical management of this, knowing that prevention is better than cure? Knowing the cost of this, we've seen that, yes, it's possible to have a thrombolysis, but it's expensive. It's 1.8 million. How many Cameroonians can afford for that? Therefore, we cannot put our eggs in hospital prevention, in hospital management. The better way to address stroke in Cameroon is to focus on the public health of it. And that's why the way forward to me, I think, is to use this framework proposed by the African Stroke Association, which is epidemiological surveillance, wherein we have to study to find out, to learn more about the burden, the incidence, the prevalence, and the mortality of stroke, understand the trends. Those are the things we need to be doing. And we need to get more rehabilitation centers, especially the specialized one, so as to improve care in this patient and to focus equally on health promotion and disease prevention, because all of these are primordial in reducing the incidence and the prevalence of stroke. And then we can invest a little bit in acute care. That means early and accurate diagnosis of stroke, pharmacological and non-pharmacological treatment, and all of these will help significantly to reduce mortality. But health promotion and disease will significantly help prevent the population from developing this condition, which is invalidating and has a huge cost economically. So the way forward is a surveillance. Like I said, we need to get valid and reliable data on stroke incidence, prevalence, mortality, and disability in Africa and in Cameroon. It's important that we get that. And for us to get this, we need to establish stroke surveillance systems to measure and analyze the burden of stroke. We need to focus on prevention, put robust systems for detection and control of major stroke risk factors like hypertension and diabetes. We need to get that. And for that to happen, we need to increase awareness. We need to do screening. We need to control hypertension, dyslipidemia. All of these risk factors need to be screened for and managed. We need to create centers for acute care and also to invest in rehabilitation. What are some of the opportunities which we have to realize all of these? We have platforms like Town Hall, which brings together brains from different angles of the medical profession. These are opportunities which we have to improve stroke care in Cameroon. We have increased health professionals. The numbers have increased over the years. Nobody can deny that. Like currently, Cameroon trains about 1,000 medical doctors every year. And from the recent launch, Cameroon will be training every year more than 300 specialists. These are opportunities which we have, which need to be made use of. We also have health professionals who are younger, and he will say youthfulness, says vibrance, says creativity, says new ideas, and we have digital technology which we can use. All of these are some of the opportunities which we have, and which, if used, I think that they can help significantly to combat stroke in Cameroon. We need to increase our sensitization. We need high quality training of the personnel. We need to equip some of our centers, get stroke registries. We have some few centers who already have stroke registers. I think Ngarka in Bamenda has it. We have stroke registers at the Central Hospital. Some centers around already have it. We need to encourage more and more people and more centers to have these registers, because they are going to help us to better follow up our patients and give us more reliable data. We need to implement post-stroke care, and we need advocacy for the prevention of these risk factors. If there is one thing I'd like to say here is that we need advocacy for prevention, advocacy for prevention. And for that to happen, it's not going to take just the neurologists. It needs each and every one of us to come on board so that together we can combat this. So if I can summarize, I would say that stroke is a debilitating brain condition. The burden is on the rise in Africa and especially in Cameroon. The challenges to adequate stroke care influence disability and mortality significantly. And so far, much has been done, but there is still a lot left to be done. So therefore, we need to come together. There is an urgent need for us to work together, and that needs to be done fast. Why does that have to be done fast? Because stroke is not a joke. Thank you very much for your kind attention. We have other opportunities which are coming up. I just want to seize this opportunity to talk about the Brain Scan Congress. We have an opportunity which brings together all neurologists, neurosurgeons, psychiatrists, and other basic neuroscientists to talk about stroke, and that will be in the month of October in Cameroon, from between the 26th and the 28th. That's an opportunity to discuss about the way forward for stroke in Cameroon. And I encourage those of you who are in Cameroon, if you can make it for that program, I think your contribution will be welcome. But before the program, I think we have town hall here this evening, and let's share our ideas and see how together we can work to combat stroke. We can see from our presentation that it doesn't only need neurologists. We have other public health experts are needed to carry out the surveillance, and even the internists and other health professionals. So stroke thing is not just for neurologists. Stroke is for everyone, and so everyone should come on board and let's together fight this. Thank you very much.
Wow. Thank you very much, Dr. Ngarka, for this thrilling and excellent presentation. You can stop sharing your screen so we see you more and really engage. This has really been an exciting presentation, really a thriller for the town hall session of today. And while we give you some time to get a glass of water, I think I should be getting around with some of the moderators. And also, Christelle, ça c'est l'opportunité pour vous de mesurer la température.
Oui.
Okay. Yeah, just gauge the temperature of the house. Let's see how people are feeling. Because I think he started when I was at 36, but I can see I'm almost getting to 38. I need to.
Oh my God.
Yeah, you know what? It's really been electrifying. So let's just get the pulse in the house while he grabs some glass of water before we get into the question and answer session.
Thank you. That was beautiful, wonderful, Dr. Ngarka. Thank you so much. Let me take the temperature while you grasp a cup of water. So I see we have the privilege to have among us Dr. Boguma. May I please ask your impression about this presentation? Thank you for being there today.
Hi, everyone. I think it was a great presentation, and thanks to Dr. Ngarka for educating us about stroke in Cameroon and the things we still need to do to improve on stroke care. I'm not a neurologist, and I think it's important that we have the opportunity to hear on this, to be educated on this topic by someone who is an expert in the field. So I thank him for his brilliant presentation.
Thank you, Dr. Boguma, for being there and for always dialing in when you have a bit of time. It's an honor for us. Thank you so much. You said you're not a neurologist, but a doctor. Let me call now a neurologist, and then I think one of the professors that we all know in the town hall, and also Dr. Ngarka. May I please call Professor Jamshi to give his impression about this presentation? And also, what does he feel about Dr. Ngarka insights and slides today? Please, you have the floor, Professor Jamshi.
Thank you very much for putting me on the spot. I was just going to be a silent listener, but you're getting me to talk. You want me to comment on Dr. Ngarka's presentation. I think all your comments that I've read and heard so far are validated. Dr. Ngarka is an extension of myself and a better version of myself. So I'm not surprised. It's much younger than me. It's more energetic. And so I think it's done a great job. To summarize to you in a few minutes, the progress we have made so far and the challenges, the huge challenges we still have. Because it's stroke, when we talk of stroke, what we see in the hospital is just the tip of the iceberg. And the patients that manage to reach the hospital, about 50%, it's estimated that about 50% die at home. So they don't even get to the hospital. So it's a very big problem that he has been able to summarize in a short time and to capture the main issues. Some things that I might highlight for our discussion in Africa in general and in Cameroon in particular, there's some risk factors that we should take particular note of. Sickle cell disease and some other blood pathologies, particular about Africa and Cameroon. And we've done quite some work to look at stroke in these subjects in this population. And they're living longer now. And that is something we need to act on specifically in our area. Infections, he mentioned that, but I want to stress, he insisted on the fact that we have a double burden in low and middle income countries. Infections, malaria, HIV, and even other infections like some streptococcal infections, staphylococcal infections. Some of them in the long run have rare risk factors for stroke, but the more we study, the more we shall discover more risk factors. So this is very important. He managed to summarize that. And I think that it's important. It's very important for the meeting that he mentioned, the meeting that he mentioned that is coming up in October, that everybody should participate in that. There are pre-Congress activities for medical students and general practitioners, then the Congress proper. So it's important for us to join. We are going to have, in a few days, we're going to have questionnaires. I invite you to participate. We're going to have questionnaires for health professionals on our website. We're going to have questionnaires for the general public. If we participate in the answering some of these questions, it will give us data that we will need to use during the Brain Scan Congress, which is focused on stroke, to be able to formulate. I saw some people were asking about guidelines. We shall be able to together build staged guidelines for the first category hospitals, for the second category hospitals, for the regional hospitals, district hospitals, and health centers. We don't have those guidelines, but those questionnaires will help us to be able to work on that. So there is this opportunities, gives me the chance to invite all of you and to ask you to invite friends and to use your networks to invite people to participate in this great event that is coming up in October, so that we can prepare ourselves for next year, and the other years to come. Thank you very much for asking me to talk.
Merci infiniment, professeur Jamshi, d'avoir intervenu. Merci pour votre contribution et votre message est passé. Sur ce, je vais renvoyer la parole à Elvis pour la suite. Merci.
Yeah, thank you so much, Christelle, for just getting the pulse of this of how we feel in the house. And I want to specifically thank the professor for taking time on this busy weekend to be part of the town hall. And we are so proud of you and the work you do. We can see the fruits of your efforts, and it's such a gracious recognition of how much you put in to bring this very dynamic professional who has drilled us in a very exciting presentation, who heard about your presentation of the conference that is coming up. And I want to promise you that at the level of the town hall, with the permission of our chair, Dr. Munoken, we are going to do our best to promote that conference. And I think the town hall is going to be a proud sponsor of that event. I want to let you know, Professor Jamshi, is that the Cameroon Town Hall for Healthcare Professionals brings together on our database now at least 1,300 Cameroonian healthcare professionals, doctors, medical laboratory technicians, pharmacists, scientists, researchers, public health experts, and nurses and midwives, all healthcare professionals from more than 34 countries. And on this platform, I think we can promise that if you send us a questionnaire, we are going to send a MailChimp out to these those who have signed out at least once on this town hall. We might not guarantee the response rate because not all MailChimp gets dropped into inboxes, but we can be sure that you can be able to benefit from some of the responses that are coming from members of the Cameroon Town Hall for Healthcare Professionals. So thank you so much, and I look forward to hearing from you about your conference, and we shall do our best to give you the support that the town hall can give. Now is the time. I'm sure Ngarka must have had some sip of water. We're going to get into conversation and discussion, questions and answers. So please, if you want to ask a question, just use you raise your thumb using the icon on our Zoom link, so we can be able to coordinate it in a very organized manner. But before I get the first hand up, which is Brian, before I get to Brian, I want to ask our presenter, Ngarka. One of the things that caught my attention was the door to needle time that should not exceed 4.5 hours. And this is a really serious challenge in a country which you mentioned, the issues of road infrastructure, the issues of lack of awareness of the triggers and the different things. But it just brings to my mind the Northwest and Southwest region that is going through a crisis now, and then just thinking of what can happen on the day of a lockdown where there are no vehicles moving, and if somebody has a stroke on such a day. have you noticed any rise or increase in the number of stroke patients coming from the Northwest and Southwest region since the crisis started? Has there been any measure to see whether that has contributed or impacted, the number of complications of stroke, or maybe just those who have died because they spent more than 4.5 hours from the door to needle time?
All right, thank you very much, Elvis, for that question. I would say that the door to needle time is for the very acute phase for thrombolysis. But now, coming to our problem in the Northwest and Southwest, one thing is sure, talking with our colleague, Dr. Angwafo, and the others who are in Bamenda, and even with a fallback to Yaoundé, because some of the patients from the Northwestern region end up in Yaoundé. I mean, the number of complications from stroke certainly have been on the rise. We don't have published data, but our experience in the hospital makes us to think so. Because those who have stroke, say on lockdown days, don't go to the hospital on those days. So they stay at home and they go there later. And we know that in stroke management, time is brain. Even when there is no thrombolysis, the earlier you start the general measures, the better will be the outcome eventually. And so these patients stay at home, they come to the hospital later on, so they have all the time to develop the complications, which could be infectious and all the other types. So increasing significantly mortality and also the sequelae which come from this stroke. So I will say that the current crisis in the Northwest and Southwest, of course, has influenced stroke incidents and also the incidence of the complications from stroke. And knowing that that condition is equally stressful, and stress is a risk factor for stroke. So in every way, that condition, that the prevailing conditions of things in Bamenda, in the Northwest and Southwest, truly have certainly impacted stroke incidents and, of course, the management.
Thank you very much for that response. Of course, just the sounds of the guns and the explosive can add the stress and increase the number of strokes. Thanks so much for your brilliant response. And before, Brian, just be patient with me before I get to you and Munoken. I want to take the opportunity to recognize the presence of Dr. Esene, who is a one-time presenter of the town hall, and just to get his comments before we move forward. Dr. Esene. Dr. Esene, are you with us? Maybe. Okay, well, Ignatius Esene, maybe before he gets to us, let me get to Brian, who was the first person to indicate. Brian, over to you.
Yeah, thanks, Elvis, for passing it on to me. And I just again really want to express my really deep respect and profound respect to Professor Njamshi, who also taught me from from the Faculty of Medicine and Biomedical Sciences, and I owe a lot of gratitude for everything that I have been able to accomplish because of his great support and mentorship. And it's really a true and deep honor to have him join us in the town hall today. And I'm really grateful for all the work that he has done across the continent to increase awareness on neurological disorders and neuroscience, and in that regard, and the stream of young people that are being inspired to choose career in neuroscience and neurology has really been fascinating, and I'm really honored to see that he's joined us today. Dr. Ngarka, I had two really quick questions and contributions. I think that in Africa at the moment, we are going through, and you mentioned this in your presentation, we are going through an epidemiological transition with the dual or double burden of disease, where we have to at the same time fight with infectious diseases, and now we are having or seeing an increased incidence of more non-communicable diseases. And it's really quite fascinating. Trying to think about some pragmatic solutions in terms of how do we build a robust disease surveillance system for stroke. It's still not very clear what the actual the incidence is and prevalence of stroke is not only in Cameroon, but across the continent, because we do not have those kinds of robust disease surveillance mechanisms like we've done for infectious diseases, for example. I'm wondering what that would look like for a disease like stroke. How do we set up some sort of electronic detection, disease investigators like we have for infectious diseases to enhance that mechanism? And I'm also really wondering if you're seeing or experiencing an increase in stroke incidents since the pandemic started. Have you seen any change in terms of the prevalence or the incidence of stroke in the last 2 years? We've heard or we've seen some of the data out about some of the neuroinvasive properties of and I read a paper yesterday that was published, I think, in Science, that talked about some neuroinvasive properties of different variants and how that's getting into the brain, and how that interplay with the vascular risk factors and the immune response, and that exacerbating thrombosis and things like that. So I'm wondering if we have seen you've seen or noticed any change, and if there are any things in that area. Thanks.
Yeah, thank you very much, Brian. Yes, during the period of the pandemic, for sure, we had, I wouldn't say incidents, because then many people really didn't come to the hospital. Most of them ran away from the hospital. So if we were to look at the hospital incidents at that time, it might be difficult for us to know if there's an increase or not, because some did not come to the hospital. But at least one thing that we know is that we had many new cases of stroke from the disease itself. We had many patients, whom I saw, who didn't have any other risk factors, any other major, most of the major vascular risk factors which we know of, but had stroke. We had a good number of them. So it is highly probable that some of the variants of this of SARS-CoV do affect the brain and increase thrombotic events and the risk of developing stroke. Yes, I think that from my experience, we've had cases of that. Now, coming to what are the effective ways we can do to really get reliable data, robust. I think it starts with records. If all our hospitals, first of all, could have good registers or records that keep all those who come there, it's going to be helpful. We still have hospitals in this country where people consult in books, and that makes it very difficult to have information, robust information about stroke. I think that one of an easy way for us to have that would be to institute, either by policy or whatever, that every hospital has a register where all patients are recorded. And that could even be done through electronic medical recording. I don't think that that's complicated as such. Those are very feasible things which can be done. If such if such are put into place, it's going to help significantly it's going to help us store data, and we'll have more reliable data on stroke. And even we could carry out community-based activities, a community-based assessment, evaluations. We can have information from that. So I think that the main thing will be we start at the hospital and then we move into the community. And for that to happen, the population need to first of all be sensitized. Because from a little experience about community interventions and things is, most of those who have neurological conditions, which are generally very stigmatizing, people tend to hide them in their homes. And so we need to go into the field to get those who are hidden in their homes in order to have real-time data on stroke incidents in our communities.
Great, thank you so much for the response. Muno, you're the next person, and then we are going to get to Samuel Fondo.
Oh, thank you, Elvis. And as always, I will start by thanking our professor who is here, Professor Njamshi, and just to say thank you for being here, for the training he gave us. Most of us sitting here were part of his training. We went through training through him, and the advocacy he has had so far in training the young generations of neurologists that have been able to manage patients that we do know of, my mom included, and just to thank him for being one of those who has been engaged in making sure that the young generation gets better in every way than the older generation. So I would like to make some contributions, then ask some few questions. So the first really is an advocacy I want to put out there. I know I've done presentations here in the town hall before for sickle cell. I'm an oncologist and a hematologist here in the US. And sickle cell is one of those diseases that is really neglected, despite the fact that we have more patients. The burden of sickle cell in Nigeria, which has the highest population in Africa, is more than that of any other where in the world. Nigeria has the highest number of sickle cell patients compared to the rest of the world combined. And you get to see that in Cameroon also, we do have sickle cell, and we have the Bantu subtype, which a lot of people don't know about, which tend to have more strokes. Most of them do not see their fifth birthday. Still, 80% of sickle cell patients do not see their fifth birthday. Most of them die of strokes, micro strokes. And it's one of those diseases that if you're dealing with a sickle cell patient, you should be careful and know that they are prone to having strokes. And what we need to, in order to take care of these patients, we don't really usually have them available. Getting exchange transfusions, even the rate of use of hydroxyurea is very low. The new medications that are available in first world countries where they have a low burden of the disease are not even available in Cameroon. So advocacy has to go into that light. Things like crizanlizumab, vosalotol, all these new medications are actually not available back home. Even getting blood products becomes very difficult. So advocacy for people to go donate blood, to make it something which is part of our day-to-day life. It's something that we need to do. And knowing that infectious disease, there are others who are infectious disease doctors here, the burden of HIV also is one of those things. My first part of the whole discussion is really about prevention. I've always said, once someone has a stroke, there's very little you can do, very little. Even here in first world countries, even in the US, there's very little you can do once they have a stroke. Few of them are really gonna recover. So those who are endocrinologists, diabetic patients, those who are internists, those who deal with hypertensive patients, those who even deal with gastroenterologists, those who deal with patients who smoke, who drink alcohol, the level of alcohol burden in Cameroon, just all measures to prevent weight loss is something that we should really talk about. Now, my next part, this was just a little discussion for us to reflect about, but getting into the aspect of stroke care, post-stroke care. When my mom had a stroke, it became so clear to me. I was looking for Dr. Ngarka knows he was part of those who actually made her get better. Looking for a physical therapist in Cameroon who is trained, who knows how to take care of stroke patients becomes difficult. Not everyone can afford it, and it's not integrated into the care in most hospitals of these patients. Looking for a speech therapist is impossible in Cameroon. Getting help, especially now that we're living from we used to have family engagement was very involved in Cameroon and other African countries, but we're getting into a situation where few family members can devote their time to take care of patients. So getting nursing aides, nurses who are specialized in actually helping patients with activities of daily living, instrumental activities of daily living becomes very impossible in our setting. No availability of health insurance, which I think the Ministry of Public Health is working on it. I know a lot of people say I'm political, but that's true. They're trying to provide universal health care to all Cameroonians. I hope this gets to a point where we can do this. And it's just some of those things that may help in the future, even availability of medications and the right medications to give these patients. Some of the time it becomes difficult controlling all the comorbidities that are available during the time of stroke. I also found it difficult getting an MRI. At the time, especially in Yaoundé, I would say that the old hospitals have been abandoned and the new hospitals are being built. I think we have a problem with maintenance. because CSU doesn't have an MRI. A lot of old hospitals that we do know were referral hospitals, and they still have level 1 referral hospitals. They don't have equipment that level 2 hospitals do have. And this is not really for Dr. Ngarka to answer this question. I think it's for us. We are the young generation, and I know a lot of my classmates that are already in the ministry. Some of them are advising the minister. Some of them are making such decisions that we need to get to the point where we can advise also on us trying to actually renovate what we have before creating a lot of new things. New ones are always good, but having the old structure staying without any form of repair becomes really difficult for us to move forward. And what do you think about, I know stroke becomes very complex for you you need multiple ministries. I always say that the Ministry of Transport to make sure that roads are well taken care of. You do need also other ministries that are involved in trying to help you get patients from home to the hospital on time. Education is also a part of this whole thing. What do you think, Dr. Ngarka, would be the best policy going forward? Public health-wise, I don't want to go into the hospital, it becomes complicated. Public health-wise, for us to help people who have metabolic diseases right now, help stroke patients be able to receive care in an accurate way or prevent stroke in the first place. Thank you.
Thank you very much, Dr. Mono. I mean, I think you just hit it where where it's hot. The real take-home message of this presentation today is for us to focus less on curative measures, but to see how much we can do to prevent. And I'm pleased that on this forum, we have different specialists, people from different fields. And this will need the general practitioner to take blood pressure. The prevalence of hypertension in Cameroon is about 25%. And more than half of these people are not on treatment. And for those who are on treatment, barely half of them are well controlled. So we see that treating hypertension is not the job of the neurologist, it's the job of the general practitioner. So the general practitioners who are here, we need them. We've spoken about stroke registries and epidemiological studies and all of that. We have public health specialists here. You are needed. We need your ideas. We need your input. We have neurosurgeons here and different fields. Just to name a few, we have nurses here. We need nurses who can think carefully about a policy and a plan for stroke care in resource-limited settings. We need such measures for us to really combat that in our milieu. Coming to your question, I think that the first thing which the ministry needs to do is to get a plan for non-communicable disease, these major risk factors, which is get either a policy or to get a sub-department that is working. There is a department in charge of non-communicable disease, which I think that they will need to get more funds, and that department needs to get very active in order to sensitize the general population, to screen for these risk factors. We do more, we do screening, and subsidize the cost of treatment for those who already have these risk factors. One of the major challenges some of them have staying with the treatment is because it is costly. For someone who is taking antihypertensive, these drugs are usually costly, and it's difficult for them to take them regularly. So it's important that the government sets in place a mechanism to reduce the cost of these drugs and also to sensitize the population. And they could even give some more incentives. There are several ways which that can be done. I think that's at from the level of the ministry. We have other structures could even put some incentives for people who have, say, who have lost weight. If somebody can lose weight, or if somebody eats healthily, or somebody who has a well-controlled blood pressure, if you're hypertensive and you're able to stay on your treatment, they could give you some small incentive to permit you better remain adherent to your ongoing treatment. But to me, I think that the best thing which will work will be for the government to sensitize the population, to get a department that is working and to screen. Those who are screened are put on treatment as soon as possible. And those who are on treatment, to ensure that the follow-up is easier.
Thank you. We're going to call on Samuel to ask his question. Then there is a question that is on the comments on the chat section of our Zoom call. And after Samuel, I'm going to read the one from Okomape. Samuel.
Okay, thank you for giving me the floor, sir. Good evening to all the great doctors in the house. Good evening to everybody. I'm Samuel Fodop, a medical student from Cameroon. And I would like to start by thanking Dr. Leonard for the wonderful presentation. So my question is the following. He spoke a lot about prevention, and that's what really caught my attention. He spoke about sensitization, policy making, advocacy, research, and many other things. I would like to ask, is the healthcare professional alone capable of ensuring all these things? Or there are other entities that are supposed to be involved? If yes, which ones? And my second question is, as a medical student, as a healthcare student and a future healthcare professional, what is my role in preventing stroke, which is an enormous public health burden? Thank you.
Very much, Dr. Fondop. Or Fondop, no, yeah. I think it starts with you. You need to know, firstly, that you are at risk of developing a stroke. So you need to eat healthily. I need to maintain a healthy lifestyle and do sports regularly. The next thing is to make sure that you educate those who are around you. You educate your family and your neighbors and your patients. All your patients you meet, spend time and educate them on the risk of stroke. And for those who already have risk factors, which hypertension stands as the first, make sure that they are put on treatment early and ensure that the blood pressures are well controlled. If you do that, you will significantly reduce or have contributed in reducing the incidence of stroke in our community. And the second question was about, what are the different stakeholders? I think to combat this, we need the Ministry of Health is one. We need the whole government as a whole, because we need finance in order to implement some of this policy. We need the Ministry of Transport, the Ministry of Public Works to make sure that the road network is better. We need even security to make to ensure that all the regions of the country are safe and people can easily move. And the Ministry of Health has a great part of it, which is, like I said earlier, is to put in place a policy and for screening, early screening of non-communicable disease, which are risk factors for stroke, like the hypertension or the diabetes, and those who already have other infectious conditions, which are risk factors for stroke, make sure that they are followed up and put their risk factors within check. I think in summary, we have different ministries, and even in the Ministry of Public Health, a lot has to be done at the level of prevention. I hope I answered.
Yeah, you did, Ngarka. Thanks so much. And there is a question for you that is in the chat. It's from Okomape. Thank you very much, Ngarka. I learned a lot. I have this patient who is neither a diabetic nor hypertensive, presenting with signs of a stroke, which actually disturbs her speech. Can we term this a silent stroke, or what must have been the cause of this? Any differential diagnosis for stroke?
All right, thank you. Yeah, I think we'll need to have more information about the patient. Just slurred speech, so many things can cause that. Depends on the age of the patient. There are many things which we'll need to find out. Stroke is not the only cause of slurred speech. We could also have other differentials. If it's a woman, we could have other inflammatory disease or space open lesions, which are a very common differentials for stroke. So I think it's difficult just from this presentation to state all the possible differentials, but having more insight about the patients will help us better orientate you on the management on what to do with the patient. I think you can contact me after this and let's discuss about the patient.
All right, thank you. And another question from Jules Senghor. Docteur Ngarka, quelle serait la physiopathologie de l'AVC déclenchée par le facteur psychosocial que vous avez évoqué?
Yes. All right. Oui, je pense qu'on a plusieurs facteurs on a plusieurs choses qui peuvent intervenir. On a le stress. Pendant le stress chronique, on a la libération des facteurs antioxydants qui vont aller jouer, qui vont aller avoir un impact au niveau des vaisseaux. Soit ça peut fragiliser les vaisseaux, ou ça peut favoriser la prolifération de la partie intérieure des vaisseaux et qui peuvent me prédisposer soit à avoir soit un AVC ischémique ou un AVC hémorragique. Donc, c'est plutôt par le biais des facteurs antioxydants.
Okay. Thank you so much. And what a beauty of bilingualism. Le facteur génétique, this is still from you. Le facteur génétique influence-t-il sur le système cardiovasculaire ou sur le système nerveux central?
Oui, mais les facteurs génétiques peuvent avoir un impact sur les deux. Sur le cœur, on sait qu'on a les problèmes cardiaques qui sont génétiques et on a aussi des problèmes vasculaires qui sont aussi génétiques. On sait qu'on a les microangiopathies qui sont génétiques. On a même les macroangiopathies qui sont génétiques. Donc, tout cela peut prédisposer à développer un AVC, soit ischémique ou hémorragique. Donc, ça peut avoir un impact sur le système cardiovasculaire et sur le système nerveux aussi.
Good. And before I get to Edwidge, who sent another comment, let me bring in Isa Sase, whose hands has been up. And after that, we're going to have Carson Matthias. Yeah, sorry.
That's fine. Thank you. Thank you very much, Dr. Ngarka, for the great presentation. I learned so much this evening, and I appreciate so much the emphasis on education and sensitization. And I also come on that. I have a suggestion, a comment there, like it's also important that when we do the education and sensitization, for example, in forums like this, it's good to include also non-professionals to come learn something, like, sharing the link widely among also others in the community. And in addition, I also want to say, this is not only for maybe the government, it's also important. Many youths are involved in social media today. So when we do social media things like this, we should try to ensure wide publicity. It will help us in our sensitization and education. And my one question that I have is, which of the risk factors do you think has a greater effect in your opinion? Because I think if we know that, then maybe that is the best area where we can get more impact or more effect. And how do you think, or what more can be added in that domain? Thank you.
Thank you very much, E.R. Ruth, for your intervention. You are right that for such presentations, it's good to have a non-medical personnel who can come and learn. It's true that some of the things that we share here might be a little technical, but I think the team will look at that. So we see how we could maybe include a non-medical personnel and they could also come and learn from that. One risk factor stands tall amongst all the others is hypertension. Hypertension is a leading risk factor for stroke worldwide, be it amongst Caucasians and Blacks, it's the same. It's responsible for more than 30% of all strokes. So if we can focus on screening and treating hypertension, I bet you we will reduce significantly the number of people with stroke. And if we could prevent hypertension by ensuring healthy lifestyle, doing physical education, reducing fatty meals, it will help to reduce hypertension and stroke.
Yeah, thank you so much, Ia, for your comments. And we will do our best to see how we can reach out to non-medical professionals as much as we can. But it will interest you to know that this session is being followed live on Facebook right now. And most of those we have seen from our statistics and metrics are that most of those who follow us on Facebook are not medical professionals. We also have a YouTube channel. After each edition, we download this session and we host it on our YouTube channel, and we share the link during the next session. And this is open. You can share the link to other people on your network. So if you look at the chat, you can scroll on the messages right up. You will see all the links of the YouTube links of all the previous channels. You will see the YouTube links for those topics that interest you, and you can share it with your network and even non-medical professionals. So, but we will continue to see how we can reach out to more non-medical professionals, and ideas are welcome. Thank you so much for your contribution. Carson Matthias is going to be the next person, and then we'll take Boko Matitanji before we get back to the next question that was from Edwidge.
Thank you for passing me the command. And I just want to say to Dr. Ngarka, thanks very much for your brilliant presentation. I'm very proud to say I studied with Dr. Leonard Ngarka for 7 years in med school. And I'm proud to say I'm seeing him making great strides. And just focusing on one part about the therapeutics, especially because I know we can't but much belabel the public health aspects, which is more of prevention. But he spoke on something about the cost of thrombectomy in Cameroon, which I still say it stands at 1.8 million francs CFA. I just want to know where is thrombectomy and thrombolysis actually done in Cameroon, and who does it? And do we have any interventional radiologists, interventional neurosurgeons who are actually doing these procedures? And what centers are they done, and what is the time frame of these procedures in the various centers? Thanks.
All right, thank you very much, Dr. Asangawa. Like you saw, we have a paper, and we've done 4 so far have been done. I'm wondering if I should do a publicity of a center here. Yes, most of them are private institutions. All right, and what is done is thrombolysis, not thrombectomy. It's good I precise that it's thrombolysis, not thrombectomy. And all what it takes is for the patient to arrive on time. And for the cases which we have, we have teams which have been trained already, and the protocols explained to them such that if we have a patient who comes with a focal onset neurological deficit, they know what to do as early as possible to exclude a stroke. If that is done, the team can be contacted and drugs bought and the thrombolysis done. So we have centers that do that. We have worked on that. We've set a protocol for the central hospital already where I work. We also have there's a private clinic in Yaoundé, Jourdain, also, which does it. And I've heard, though I don't have the information verified, I've heard that it's been done at the General Hospital in Douala and maybe the military hospital, but I've just heard, just like rumors. I don't know if I can't vouch for that, but at least I know that we have the protocols at the Central Hospital and also in the private clinic.
Yeah, thank you.
Yes, Elvis, I just want to add something here, because it's important that that's medical thrombectomy usually needs to be done within the first 4 hours or 4.5. That's usually the limit. And I think Dr. Ngarka mentioned it in his presentation. It was well spared in his presentation. And giving it, you just need to know the risk factors, make sure the patient is actually meets the criteria to get it. And the protocols are very clear on giving it. We do give it even in areas where there is no neurologist on site. You can do televisits and monitor it. You need to have the medication and be able to give it and monitor for bleeding, meaning you should be able to do a CT scan in case you actually suspect a bleed. Because the initial CT scan that you do for patients who come in with a stroke is to rule out a bleed. You're not going to pick out a stroke if they just had a recent stroke. So you should be able to monitor for that and be able to do it. On the other hand, mechanical thrombectomy, even in industrialized countries, my mom had a stroke in England in 2018, and mechanical thrombectomy was not standard of care. My mom had a stroke within 30 minutes from the time she had a stroke. When my other sister, who is a physician, called me, she was also a physician, and we took her to the hospital, and it was a middle cerebral artery stroke. I was clear about it. I spoke to the neurologist in London. It was not a standard of care. Though it was a standard of care in the US, in New York, where I worked, that was the first thing we would have done. We would have taken her for mechanical thrombectomy. And mechanical thrombectomy has a wider range of time which you can do it as an internist, and those of us who practice here, you can go up to 16 hours actually. But there is a wider time frame, so most patients qualify for it if it affects one of the major arteries in the brain, either the middle, the anterior sometimes, and the posterior sometimes. But you need to be able to get the patient there, and the patient qualifies for it. So I want to say not all developed countries even do that as standard of care. I think right now in the UK is standard of care, but then it was not. In order to be a stroke center here in the US, you need to be able to do mechanical thrombectomy, but there are still rural hospitals that cannot do it. And quality of those who do it, it can be done by an interventional neurologist, it can be done by an interventional radiologist. In some rare cases, it can be done by an interventional cardiologist because they are used to the penumbra. The machine that does it, they are used to access in order to go to the heart, so they can easily go to the brain too when they are trained, because you just need to have access and go to it in areas where there is lack of resources. So even here in rural America, it's not clear. Not every center offers mechanical thrombectomy, but the outcomes are spectacular. They are spectacular, from a person who cannot move their whole arm or anything to someone who is moving. But the risk also are there. We have had patients who have actually transformed to bleed. So you need to know exactly what is happening, know what you're doing. But I just wanted to put in this so that people should not feel that because we cannot. Israel, I know Carlson is calling from Israel, they're highly technological, it's a smaller country, and a lot of times most technologies do go widely functional in Israel, a lot of them, but the rest of the world doesn't match that same speed. So it's important that we know and put things in perspective. That is why I've always said stroke management is very complicated once you already have a stroke. Most of the time, 80% of the time, you're going to be dealing with the sequelae. And physical therapy is so paramount. I was not a big believer till I got to a point where my mom has drastically improved all. Her MRI does not match her physical abilities now. Dr. Ngarka is going to tell you. Her MRI, the whole left side of her brain is gone. Left middle cerebral artery, but she's able to, we took her from England in a wheelchair, but she's able to walk, do her activities of daily living by herself, just because of the extensive physical therapy that she received. It rewires the brain, and that's not what we're going to talk about here today. I'm not a physical therapist neither. I'm not a neurologist. I'm an internist who is specialized in oncology, but I want to tell you it works. And I want to give high emphasis on that specialty, and it needs to be developed properly in Cameroon. Really, we need to train subspecialties in physical therapy going forward for those who have already had a stroke. Now, thrombolysis, expensive, how many of us can do it? How many centers will be able to do it safely? We need to really improve things. Mechanical thrombectomy is far away. We need to get very good in accessing and doing cardiac catheterizations, getting people used to so that we can actually have access in order to do all further complicated things going forward. But I think this is going to help very few patients. Even here in the US, it helps very few patients. Very few patients even qualify. Most people have stroke during their sleep. By the time they come to the hospital, they don't even qualify for any of these treatments still. So it's important that we talk about this. So sorry for interjecting, but I just wanted to talk about stroke just because I am very, very basic, maybe because of my mom's situation, I'm very prone in always educating about stroke.
Well, thank you so much. Your insights are very helpful, and it really is an eye-opener, also just providing an opportunity for those who might want to invest in the field of, just therapy and all that rehabilitation work. Very important. So we are almost 5 minutes to spending 2 hours together. At this time, we'll be taking the last questions from Guy. First from Bugomak Titanji, then Guy Motumbi. First.
Hi, I don't really have a question. I had rather a comment. And I wanted to say that although the main cause of stroke around the world are non-communicable diseases like hypertension, untreated hypertension, I think one of the things that is an important cause of strokes in our environments which often do not get worked up properly, are infectious etiologies. And that's, I usually get consulted on stroke patients, even in the US, when they do the workup for the non-infectious etiologies and they don't find any causes. One of the specialties that they would reach out to after they've done the non-infectious workup is the infectious diseases specialist to come and weigh in on whether there might be an infectious etiology. And I just wanted those listening to be aware of the fact that something like HIV, even in individuals who have well-controlled and treated HIV with virological suppression, they still have a twofold higher risk of developing stroke compared to someone who doesn't have HIV. And one of the reasons behind that is because in individuals who have HIV, they have chronic immune activation and inflammation, which impacts upon the blood vessels and increases their risk for developing vascular complications. So just something that I think the audience should be aware of. Secondly, in our environment, neurocysticercosis. We have a lot of people who have primarily manifestations around epilepsy related to neurocysticercosis, but one of the complications as well is stroke. And I have seen cases of stroke in patients in whom the etiology was found to be neurocysticercosis. And we can prevent that for those of us who do pig farming by kind of making sure that we are disposing of the feces of the pigs that we keep in our backyards properly to avoid exposure of individuals to the egg form of the cestode worm that causes neurocysticercosis. And then obviously there's tuberculosis, and then there are fungal etiologies that often we don't think about and don't work up for in our environment. So important to also have on that differential list infectious etiologies, because for most part, they are treatable.
Thank you so much. Thank you so much for your comments.
Oh, and syphilis. Screen every single patient for syphilis and treat it. It's easy to treat. There's a lot of untreated syphilis around in Cameroon. So if you have a stroke patient, that's pretty low-hanging fruit. Screen them. If they have a positive RPR, treat their syphilis.
Thank you so much. And you wouldn't imagine the prevalence of syphilis in New York. We see them every day. So it's not just Cameroon. Thank you so much for that information. We're going to get the last question from Guy Motembi, and then we'll get around with all the moderators before we end the session.
Yeah, thank you, Doctor. So good evening, everyone. Thank you, Dr. Leonard. So first of all, I want to just wish or ask, I think, for your next meeting coming in Yaoundé, I hope you have some connection with colleagues here in Gabon to be invited there for the next meeting in Cameroon. I hope so. So secondly, for the presentation of today, I returned something like Dr. Brian talked about demographic transition. Then from that, I've been focused about like, it's very important to be careful about it, because now we're still dealing with the communicable disease, then we are already passing by incommunicable disease in our continent, in our countries. So for me, it's very important, like we say already, to try to be focused in communication, because in Gabon, I think it's the same thing in Cameroon, neurologists, cardiologists, they are very, 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 very separate for the community. Most of them, they are big on the hospital, on the clinic. Most of them, they are very difficult to find them on the community. They are not the same thing like the surgeon, like the gynecologist. For the future, it's very important for you guys or for all of us to try to make a lot of action for the sensibilization of population. Make an effort and try to do those things on community, with community, and for the community. Because if we are talking about the prevention, we have to try to be together, try to use all means we have to try to avoid kind of, I don't know, neurologist defect and stuff. Then for the psychological factors, I think the stress here in our continent, it's a problem now. Now, stress, we are not talking about like a risk factor. We are coming from 10 or 20 years ago. Now we are talking about as a disease, stress as a disease. Stress right now is not the risk factor as a disease. As most of us, like people between 30 or 40 years old, we have a bad things, I think I can say lifestyle. Most of us, we need drugs, we need drink, we need smoke, we need like after work. In Gabon, we use after work, go then sleep, take beers and stuff, and come to sleep very late and wake up in the morning, doesn't practice sport and stuff. I think we have to try to talk that thing a lot of with our population to try to desensibilize them about it. Thanks, God.
Oh, thank you so much. Thank you so much, Guy Mutembi. And we are so glad that you are calling in from Gabon. And we will hope that you can communicate and send some indirect messages to Leonard and to also Professor Jamshi to hear more about the events that is coming up. So maybe you might have some candidates in Gabon that are interested in being part of that event. Thank you so much. And we look forward to see you more often on this platform every 2 weeks. At this point, we're going to take a round with the moderators. I'll start with Brian. Brian, some last words for today.
Yeah, thanks, Elvis. I think this was a really insightful session, and I personally learned a lot. And it was really very, very educational. Really very, very thrilled about this. And I'm hopeful that we will be able to, I'm hopeful that during the session that's coming up in October, some conversations will be had on how we can establish some better, even if it's passive surveillance mechanisms at the Ministry of Health that can really help to have really an estimate, really a good proxy of what the numbers are and what's driving those, and if they're infectious causes, and if they are non-infectious causes, what are the characteristics of those. And in that sense, it's going to be a lot easier for us to monitor and to monitor the epidemiological strengths of the etiologies of stroke over time. So I hope that we can have some of those conversations at that time. And I think it's really important for us to start thinking about how we can transition into really electronic disease surveillance systems at the Ministry of Health that can really help us have a great estimate of what the magnitude of this problem is. I also noticed that Dr. Joshua Tambe is in the hall, and it really would have been very helpful to hear about a radiologist take as well on some of the diagnostics. I think not only for stroke, not only for the non-infectious causes, but even neurocystic causes is still very important. To have a radiologist. Imaging is critical as well. So I think it would have been helpful. But I think that's a conversation we can also take into the parking lot after this session, where we can maybe discuss a little bit more about how we can take that to the next level. So I think it was a very insightful presentation, Elvis, and thanks a lot, Dr. Ngarka, for joining us, and thanks a lot to Professor Njamshi as well for joining us. It was really a pleasure to hear from you. Thanks.
Thank you so much. And Alison is in the house. Alison.
Hi, Elvis. Hi, everyone. I'm so sorry I couldn't join fully today just because I have competing priorities, but I just couldn't miss this session. Dr. Ngarka, thank you so much. This was so exciting. I learned so much. I remember when my mom found out that Dr. Ngarka was presenting, she was like, oh man, that guy is such a gentleman. And she's like, Alison, you have to attend this session and bring back the feedback. So I said, okay, mommy, I'm coming to take down notes. So thank you, Dr. Ngarka, for delivering as expected. And to all of you who've joined the town hall for the first time, thank you so much for joining, and you're welcome. And Elvis, over to you.
Thank you so much. We all agree Ngarka is a rock star when it comes to this topic, and we saw it from the numbers that dialed in today. Christelle, dernier mot?
Oui, Elvis, merci beaucoup, Dr. Ngarka. C'était très intéressant, c'était très édifiant aussi, à voir le nombre de participants, plus de 60 sur Zoom, et j'imagine encore plus sur YouTube et Facebook. Moi, je retiens les aspects précliniques, notamment l'éducation et la sensibilisation pour réduire les facteurs de risque cardiovasculaires. Et c'était très important d'échanger avec vous et d'apprendre tout ce qui se fait déjà dans ce domaine, non seulement à Yaoundé, mais aussi dans les régions. Merci infiniment d'avoir accepté l'invitation. Merci à chacun d'avoir été là et très bon week-end à chacun. À toi, Elvis.
Thank you so much, Christelle. It's always a pleasure to have you here every fortnight. Now we'll give the opportunity to our chair to give us his thoughts about the session, and then I'll get some last words from our own professor. Then we will get the last vote of thanks from Ngarka. Then I'll do the summary of the day. So, Chair, over to you.
Wow, thank you very much, Elvis. And just want to use this opportunity to tell those who are new into the town hall that this is a platform that was co-founded by myself and all the moderators that you see here. And we think it's a platform for all Cameroonians. It doesn't belong to me, nor does it belong to the moderators. It belongs to all Cameroonians. Our goal is to create a platform where we can bring health professionals together, talk about health problems and propose solutions, and also get people to network where they can meet others and start projects in Cameroon, where they can meet others and also start other groups. We are just not one of those groups that is limiting ourselves. We are really there to provide a platform. That is why Elvis actually created the name Town Hall, meaning that it's a platform where we can just talk to each other and get to find solutions for healthcare problems that exist in Cameroon. Please, you can share this to known healthcare workers. We have had engineers who have presented here. We have had people who have had ideas like HealthLink, like Waspita. There are many others who have come into this platform who have created good ideas that can help Cameroon move forward. So our goal really is to help the health sector in Cameroon move forward. And I told you guys some few months back that the minister had promised to come to the platform. We hope he gets here one day. But it's a platform really, and everyone should feel belonging. Be it French being your original language or English, you can speak in any of the languages that are allowed and official in Cameroon, please. And we are going to respond in the language which we are fit and we are best capable of. And in the next 2 weeks, we're going to have an interesting discussion. I'm just going to give you guys a headline. It's going to be on radiation, the radiology. It's going to be very interesting. And the flyers are going to be out as soon as possible. So please do not miss. It's someone whom I respect very much. And you guys are going to have a thrill time here in the next 2 weeks. So I think with Elvis, it just keeps getting better. So that's what I want to say. And I want to thank Dr. Ngarka. He is a wonderful physician. And personally, he took care of my mom, who recovered a lot. I took her from England in a wheelchair. Presently, she's walking and able to do her activities of daily living, her instrumental activities of daily living. And I just want to tell you, thank you very much for all what you do and all what you have been doing. So Elvis, thank you very much.
Thank you, and I must always thank you for your leadership. We do this work all the time in the background, and we always tell you this is all voluntary what we do here. We have kept the town hall a completely apolitical platform, voluntary. All the volunteers, actually, all the moderators volunteer their time. We want to all do this because we think we can make a difference in our country, no matter where we are. That's why we have people dialing from Japan, from Israel, from 34 different countries at different times, all because of the interest and love for country. At this point, we want to call Professor Njamsi to just give some last words before we hand the floor to Ngarka.
Thank you very much, the leaders of Town Hall. This is really interesting. I think it's Ngarka who has brought me in here. I mentioned to you that he's the better version of me. So I want to thank you all. I can see a lot of zeal. I can see a lot of commitment. And one of the things that we need for the development of our country and our continent is the diaspora. And I can see the power of that. The brain is about neurons connecting in networks, and that's why it's such a marvelous organ. I hope the society will understand that if we connect our brains as neurons connect themselves to make the brain, we would be a great big brain for our country, for our continent, and for the rest of the world. That is what Brain Research Africa Initiative is about. It is about using the available evidence that is there in science, and especially brain science, for the development of our continent. And I think when I see the zeal and enthusiasm and commitment of this group, I am very, very encouraged. And I think that together and with more people, as you have said, we're going to do great things, not just for our country, but for our continent. Thank you so very much. And I will like to be with you more often than I have been. I've just discovered you, and I'm very, very impressed. Blessings, and may God bless you and bless all of us.
Thank you so much, Professor. Very, very powerful words. Words that I can take for a campaign if I were a politician. Very, very insightful words. And we really want to thank you for the great work you are doing in the country. Your name is a household name when it comes to this subject matter, and the numerous students that you've trained and specialists that you've produced is really a testimony of the great work you are doing for our country. And we continuously thank you for the work you are doing. At this point, we want to call on Leonard to give his last words and word of thanks while I'll do the summary for the day. Yeah, you are mute. Maybe you have to unmute yourself.
Yeah, thank you very much, Elvis, and to all the moderators for this opportunity given for us to share on this very important subject. A lot has been said, but I think if there's one thing we must leave here with is that stroke is not a joke. So let's join our hands together from our different fields of specialty and do what needs to be done to combat this big giant that stands ahead of us. Thank you very much and have a nice weekend.
Thank you so much, Leonard. We're so glad that we had you today. I always do some rough summary. Forgive me if I say some things that are not in place. It's just a way of giving an opportunity for those who joined the session late to just have a glimpse of what the session was like. So you told us today that stroke is a brain condition defined as a sudden onset neurological deficit. And there are two types of stroke. One is ischemic stroke that represents 2/3, and the other is hemorrhagic stroke that actually represents 1/4 of all strokes. And you mentioned some of the risk factors that are either modifiable factors like hypertension, smoking, obesity, and you talked of non-modifiable factors such as age, gender, and race. We also heard that stroke is the second cause of mortality globally, and that it is the third cause of daily adjusted life years lost in the world. This is a very great statistics. Distribution of incidence of stroke worldwide shows that low and middle income countries have higher prevalence than developed countries, and that even the high prevalence in low and middle income countries is not actually well captured considering the poor data capture system that we have, which means that this data could, or the incidence could even be higher than what is being documented. You mentioned that 86% of mortality due to stroke are found in low and middle income countries, and most of this is in Africa. And that some studies even suggest that there is something among Africans which predisposes them to developing strokes. The prevalence of depression among stroke patients is about 16%. So if we are fighting stroke, we are as well fighting suicide, which has been reported that most of suicide is caused by depression. What explains this high incidence in Africa? Leonard tried to let us know that there are genetic factors, there are issues of population growth, there are issues of sedentary lifestyle. In the past, our parents used to be very active, go to the farm. Now we are living sedentary life. There are also life behaviors like smoking that have increased, HIV, infections, just like Bogo Matitangi emphasized on the rise in infections. Also, the population is growing older in Africa. The mortality rate in Cameroon is about 100 I think 11,000 in every 100,000 population. That represents about 6.1% of the causes of mortality in Cameroon. And you also mentioned that stroke management costs about 800,355 francs per year, which represents about 80,000. And this is really expensive considering that the minimum wage in Cameroon is about 35,000. This statistics shows that stroke patients between the ages of 30 and 40 are also increasing in Cameroon. So it's not just a disease for all people. But why the burden? Why is the burden very high in Cameroon? The reasons are similar to the ones that I just cited earlier. You said the main reasons are due to life changes, sedentary life, rise in obesity, rise in hypertension, and also diabetes. But most of the cause of stroke among our population are preventable. That is a good news. So he talked about some stroke management in Cameroon and said for someone who has a stroke, he needs to be received in the hospital within an hour, and that the door to needle time should be or should not exceed 4.5 hours. And when we look at this with the reality on the ground, then we see the challenges, which are socioeconomic. The population need to be aware of a stroke. We need a lot of knowledge in our population. We need that the health-seeking behavior of the population should be improved so people can go to hospital to test for hypertension or to screen themselves. We have to improve on sensitization. There is the issue of transportation. We need interministerial collaboration so that roads can be improved for people to get to hospital in time, and that the health policy needs to actually take care of this very health condition that is important in our population. The high cost of thrombolysis was also an issue. 1.8 million francs is not cheap in Cameroon for a very important intervention like this that can save life. In the whole of Yaoundé, we have just 2 speech specialists. That was one of the very important things that are captured, because speech disorder are some of the issues that will see stroke patients suffer from. So we need to have more specialists that can be able to rehabilitate our stroke patients that have a speech disorder. But the good news, Ngarka was not just pessimistic. He actually could point out some of the good work that the Ministry of Health is doing. He said there have been recently inauguration of many other new hospitals that have state-of-the-art imaging equipment that are also very helpful in diagnosing and treating complication of stroke. A lot is going on in Cameroon. Thrombolysis, which used to be far-fetched intervention, is now possible in Cameroon. That is good news. So we should continue to see how, as far as we are Cameroonians, the different areas we can invest back home to improve on the situation of a stroke. We can invest in the domain of rehabilitation and make sure that we have more physiotherapists to rehabilitate our stroke patients. But looking at the way forward, he talked about epidemiological surveillance as a very important way in which we can be able to address the situation, being able to capture and record all cases of stroke in our hospitals. He talked about rehabilitation. We need to invest in rehabilitation. Ngarka also told us about the importance of health promotion and disease prevention. We all know prevention is better than cure, and that we need to invest a bit in acute care. He emphasized that we can also use digital technology and all other advancements in medical sciences to improve on the situation of stroke in Cameroon. And above all, Ngarka ended by saying that stroke is not a joke. And I agree with him, stroke is not a joke. That's why at the town hall, we decided to bring the best expert for you today to speak to you about stroke. And ladies and gentlemen, it was a great pleasure having you. We look forward to seeing you in a fortnight yet for another edition of the Cameroon Town Hall. Have a nice weekend and God bless you all.